Hello everyone, my name is Nehal Desai and I will be going over stroke in this lecture. As you can see, these are some of the topics that's covered on the NAPLEX. Just be aware of what what medications are used and what each of the disease states are and how they occur and all of that. So what is stroke? Stroke is essentially just a sudden interruption of blood flow to the brain. It could be some sort of clot. It could be a spread of blood inside the brain that could be preventing activities within the core parts of the brain. So there are two major types here. You got the ischemic stroke, as I mentioned, that's usually blocked by either a clot inside the blood flow to the brain. And then you have hemorrhagic stroke, which is where like the bleeding occurs around the insides of the brain. Could be between like the meninges and the spacing area here. Or it could be just in the surrounding parts of the brain here, anywhere. So, whereas this one, the ischemic stroke, is just like a blocking of blood, so you're not able to deliver any oxygen or glucose or whatever the cells in the brain need. So a stroke occurs because the brain's not receiving what it needs to get. And the first part, I'm going to go over the ischemic stroke. Ischemic stroke is essentially obstruction of the cerebral artery. Oxygen, glucose can't get to a brain cell, so the neuron cells die. Usually it could be a cause of other types of diseases, like there might be an atherosclerotic plaque rupture. As we mentioned in the previous lectures, as I mentioned in the previous lectures, atherosclerotic plaque can rupture, and then that can go into other parts of blood vessel and cause further problems. Embolus from AFib or heart problem, and can also lead to stroke, small vessel disease, all those other kinds of things that may lead to stroke. Also, when determining whether a person is getting stroke, there are some symptoms that you should understand, such as the fast mnemonic. Fast usually are things like when the face is drooping, there's weakness around the arm, where one part of the arm is just not working. Maybe just speech is a problem, but a person's not able to talk properly. There's a problem with the speech. And then also time, T for time. You need to call 911 right away, because these are some of the symptoms of stroke that a patient may be experiencing. At that point, you have to go and call 911. And so let's talk about some of the treatments here, ischemic stroke treatments. These are things like the acute treatments. First thing to admit that's usually administered is alteplase, TPA. The first thing you want to do is obviously break those clots that's blocking the blood flow to the brain, so that oxygen and glucose can be delivered. We also want to make sure the blood pressure is also controlled in the patient. Sometimes that could be an issue, and that's why blood pressure is also important and need to be managed, especially in hypertensive patients. So definitely some of the medications used for that are things like IV labetalol, like cardipine, clevidipine, calcium channel blockers, and also this beta blocker. Those are some of the medications that are used for managing blood pressure when patients experiencing stroke. Another treatment, sometimes antiplatelets are used, but they should not be used when they're already on alteplase. They should be used after, a day after using alteplase. Just because it's too much, blood thinning, you're going to that could lead to further complications later on. So better to use that within the time frames as indicated per the guidelines. You can look more into guidelines for updated information on this. But some of the therapies they use are dual antiplatelet therapy, where aspirin and clopidogrel are used together for 21 days just to treat ischemic stroke. So anticoagulation, if there is any other comorbidity like AFib or cardioembolism, you could use that, but that has to be used later on. It cannot be used while this patient is on TPA, otherwise it might lead to further complications. So they recommend to use it after 4 to 14 days of treatments. So, just keep some of these things in mind while you're studying for the exam, because time is very important when patients experience a stroke. That blood flow is being blocked, so patient's not able to, the brain in that patient is not able to get any of the nutrients it needs. So the time is very important in this case. Looking at the mechanism of alteplase, alteplase technically is a kind of like a drug that converts one enzyme to another. So it's an inactive enzyme. Our bodies usually produce something called plasminogen, which is an inactive enzyme that's actually found within our blood. And what happens is TPA is used to convert that into another inactive enzyme known as plasmin. And plasmin is used to break up the fibrin clot, which is, I kind of drew it here for you, but it's like whatever's blocking that blood from getting to where it needs to go, it's going to break this. It's just going to tear this apart here. And what happens is that clot, those pieces are going to start to get smaller, and then they're going to dissolve and go away. So that's typically how the TPA or alteplase work. They're going to convert plasminogen to the plasmin. Plasmin is going to go ahead and work on the clot, the fibrin clot. And then after that, fibrinolysis, which is the term used for when plasmin breaks the fibrin clot. So that's going to happen there, and then it's going to dissolve it. So that's what's happening in this case. Hemorrhagic stroke is another section I want to talk to you about. There are also two types here. Can be hemorrhagic, intracerebral hemorrhagic, or subarachnoid hemorrhagic. Intracerebral hemorrhage is usually where the blood is spreaded within the brain tissue. So you can see how kind of like the blood here, actually the blood here and is kind of like spread in some other part of our brain here. And whereas the subarachnoid hemorrhage is kind of like a break in like the blood pattern here and within the meninges and the actual brain part. So just showing a diagram here, just to give you a brief overview of how what the differences are here. There are some treatments, but in terms of hemorrhagic stroke, treatments are a little bit difficult in this case because you're not breaking any clots here. You're actually trying to make sure that there are clots in place to prevent that blood from going in some unusual pathway into the brain, so that the blood can flow normally. And so in this case, you want to identify the cause of it. What is exactly causing it? Are there some blood thinners this patient is on? Are they on any warfarin? Are they on heparin? Are they on any factor 10A inhibitors? So you need to know which medications on their medication history this patient is on. some of the cases might have a list, and you have to know which reversal agent to use. So a question might ask you, what is the best reversal agent for this patient when treating this patient's subarachnoid stroke or hemorrhagic stroke? So you need to understand like vitamin K and PCC for warfarin, idarucizumab, excuse me for my spelling here, for Pradaxa, uh, and Dexamet alpha for the 10A inhibitors, protamine sulfate for heparin. And you already know the mechanisms of these main medications that are used as part of blood thinners. I'm just going to show you quickly of how the reversal agents work in the next slides. Um, but this is important, and it might be a question on the test, so you should understand the reversal agent to use to prevent further hemorrhagic stroke in this case. Also, again, it's important to control blood pressure and also managing the intracranial pressures as well by, some ways like elevating head by 30 degrees, using some mannitol to flush out the fluid from the brain, or hypertonic saline just to get it out of the system. Then you can also use this calcium channel blocker. This one is special, the nimodipine. Just understand that's the one indicated for subarachnoid hemorrhage stroke. So this, I think you should at least highlight or know, because it could be a test question. So don't forget about this. This is the one medication used for subarachnoid hemorrhage. So just note that. So these are some of the reversal agent mechanisms here. I listed it here. Idarucizumab, how it binds to the dabigatran, and what happens, it becomes an inactive complex. So the dabigatran will just not work in like preventing factors and all that. So just note that this is one way to inactivate one of the medications that patients might be on as part of blood thinners. So you can't just use any reversal agent for a patient on hemorrhagic stroke. It has to be specific to that medication that they're on. So if they're on warfarin, you don't want to use idarucizumab on a patient that's taking warfarin. So you have to know which reversal agents are used for which agent. Another example here is vitamin K, PCC, FCC. You can see how basically overall the vitamin K, if you looked at my previous lecture, vitamin K is normally like produced, within the liver. It's becoming an active form. It goes through a recycling step through the V-core C1, converting from inactive to an active form of vitamin K. And you know how that warfarin kind of interrupts it by preventing, it's a V-core C1 inhibitor there. So in this case, by taking vitamin K with one of these other agents, it's going to help replenish those clotting factors inside the blood. And so the clotting factors will just return back into a blood, so it will prevent further bleeding that way. The other example I have here is the protamine sulfate. You already know that heparin binds to antithrombin 3. It's one of the proteins within the bloodstream. So that causes, or those clots, that's part of the clotting factor, where the signaling occurs here. And so this is where the protamine sulfate goes ahead and binds to the heparin and prevents heparin from binding to the antithrombin 3. Now, what you might ask is, yourself, what if heparin is already bound to antithrombin 3? That is okay. As long as the protamine, if the patient is on heparin and they have, whether it's free in the blood or it's bound to antithrombin 3, as long as protamine sulfate binds to a part of the heparin drug, it's going to make that whole complex inactive. So it will not prevent factor 10A or factor 2A or any of the other clotting factors that's in the blood. So that's an important one there as well. So just note some of these mechanisms here. Some of these are interesting. Take a look at this next one, the 10A inhibitor. So if there's a factor 10A inhibitor, like any of the low molecular weight heparins, or the DOACs, direct oral anticoagulants, say patients taking Eliquis and then they, want to, take it as a blood thinner. Well, there's another medication here that will prevent that Eliquis from working. It's called indexament decoy receptor. It's going to act like a decoy receptor. So it's going to act like a factor 10A inside the blood, but it's not going to be the actual factor 10A protein. It's going to bind to, so the medication is going to bind to the fake one, so that it doesn't harm the other or prevent the other actual factor 10A within the blood. So you can see how this is kind of working. The decoy receptor will prevent factor 10A from inhibitor from binding to the actual factor 10A. So those are some of the mechanisms I just wanted to list out here for your reference. As I said earlier, understand how protamine sulfate can be used in either way. And also knowing, some of the calcium channel blockers, you should know how nimodipine and are special for the subarachnoid hemorrhage and those kinds of things.